Thank you for joining us for the Coriel Personalized Medicine Collaborative's educational session on age-related macular degeneration. This evening we have two wonderful speakers. We have Dr. Ravi Goel, an ophthalmologist who will talk to you about age-related macular degeneration, some of the symptoms, treatment, and current findings in that area. And we have Tara Schmidlin, a board-certified genetic counselor who will discuss how to interpret your CPMC results. First, let me introduce Dr. Ravi Goel. Dr. Goel has lived in South Jersey for more than 35 years. He graduated from Cherry Hill High School East and then earned a BA in Ethics, Politics, and Economics from Yale University. He went on to earn his medical degree from the UMDNJ Robert Wood Johnson Medical School. He completed his internship at Cooper Health System, and finally his ophthalmology residency at Greater Baltimore Medical Center in 2001. Dr. Goel is board certified by the American Board of Ophthalmology, and he's been elected as the president of the New Jersey Academy of Ophthalmology. We're delighted to have him here this evening to discuss with you age-related macular degeneration.
The annual percentage of patients who are becoming legally blind is about 200,000 per year right now, and this is going to increase to about 500,000 in 2030. More importantly, if you look at causes of visual impairment in the population of patients over the age of 40, you see that you have cataracts, macular degeneration, intermediate and advanced. I'll go over both of those. Diabetic retinopathy and glaucoma. If you total them up here, this is the very concerning number here. 1.7 million patients today have what's called advanced macular degeneration, where they have very poor vision. Going forward, this number is going to be estimated to be about 3 million in 2020. So right now, it's about 7.6% of the population over the age of 40. And causes of blindness by ethnicity. 54% of, if you look at blindness by ethnicity among non-Hispanic white patients, 54% of patients, the cause of their blindness is due to macular degeneration. 60% of patients who are non-Hispanic black, their cause of blindness is cataract and glaucoma. So this is a disease which disproportionately affects Caucasian, white Caucasian Americans. Macular degeneration, as I stated, damages the central macula. And if we look at, here's a basic anatomy schematic of the eye. This is the cornea. So somebody, if you have kids or grandkids who have LASIK surgery or those procedures, that's on the cornea. Patient, this is the lens of the eye. This is where you develop cataracts when somebody has cataract surgery. This is what's called the vitreous gel, and here is the retina. The retina has these multiple layers, and the damage in macular degeneration occurs right down here. The highest blood flow to any part of the human body is actually to the macula, to the retina. And if you look at the percentage of blood flow to the retina, to the central part of the retina, which is called the fovea, that's the highest percentage of blood flow. It comes from these blood vessels. In macular degeneration, a very simple schematic is that this membrane here, called Bruch's membrane, that becomes damaged and that breaks. And then these blood vessels grow through Bruch's membrane and they cause swelling, and they eventually lead to decreased vision. This is the normal retina here. Again, you see this is called the retinal pigment epithelium, and right below that is Bruch's membrane, and here are those blood vessels from the choriocapillaris. That's where blood flow is highest in the body, highest by percentage. Macular degeneration damages the macula. This tissue, I'm sorry, this may not come out on the webinar, but this tissue right here, this line right here, becomes damaged. This grayish line right below the retinal pigment epithelium becomes damaged, and bad blood vessels. You know from diabetes, if you have diabetes, we often say, it's important to see your ophthalmologist, your nephrologist, and your podiatrist, because they are diseases of small blood vessels. Bad blood vessels can grow in diabetic retinopathy and also in macular degeneration, where the barrier between the inner part of the retina and the outer part of the retina becomes broken and blood vessels can grow through. Here is a schematic. I'm going to go over each of these. Early macular degeneration, intermediate, and advanced. And advanced is broken into neovascular and non-neovascular. And I'm going to go over this slide one more time at the end. But early macular degeneration occurs in patients who are typically asymptomatic and don't experience any vision loss. And when we look at these little yellow dots here, these are what are called drusen. Sometimes you'll go to your physician, they'll say, oh, you have drusen. And based on retina studies, we've characterized the size of these drusen as between less than 124 microns and 1,000 microns equals 1 millimeter. So something between less than 124 microns or 125 microns or more. And patients who have early macular degeneration, typically they're asymptomatic, and they have very, very small drusen or a few medium-sized drusen. And these are very small drusen, these little yellowish sort of, you could call them opacities, but they're acellular material within the retina. And I'm going to show you exactly which layer they occur in. But these patients can be followed yearly. These AREDs, I heard when I was coming in and listening, some of you mentioned AREDs vitamins, and also the Amsler grid was mentioned. But AREDs vitamins, I'm going to go over that study today. For these patients who have early macular degeneration, AREDs vitamins have not been proven to work. Now the question always comes up, well, what if I'm destined to get more advanced macular degeneration? Should I start taking vitamins? And we'll go over those results. But if you look at 5-year risk of a patient who has early macular degeneration becoming advanced, where they have severe vision loss, less than 2,200. A major study called the age-related eye disease study, where the major findings came out in 2001, 2002, showed that the risk of advanced macular degeneration is about 1.3% within 5 years. Now this number here will be different for early, intermediate, and advanced. The 5-year risk is 1.3%. Early macular degeneration, you have these little drusen, again, these acellular material is growing, is breaking that barrier between the inner and outer retina. Here's the retinal pigment epithelium, and you see these little mounds here. And here's, again, that blood, the rich blood flow to the eye, that choriocapillaris. And these are all little drusen, all little yellowish material. Here's another schematic. And I like to be very heavy on pictures because I think it's important to sort of see how different artists will view changes to the macula. But here you have drusen is forming. And the eye, the cellular layers of the eye, or the retina, regenerate every day. So I think of it as really is cells are regenerating and the retina needs the ability to remove debris, and I think this is what's happening. Is that you're having a breakdown of the ability of the body to regenerate itself, and these drusen get deposited within the retina. Intermediate macular degeneration is defined as many medium-sized drusen or one large drusen, and the way to think of a large drusen is actually, if you look at the diameter of this blood vessel right here. The diameter of the optic disc is 1.5 millimeters. And the diameter of a typical vein in the retina is about 125 microns. So if you look at various areas of drusen, you can estimate the size on the picture just by looking at the optic nerve, which is 1.5 millimeters, 1,500 microns, or the width of a retinal vessel. A retinal vein, because these right here are arterioles, and right next to them are thicker veins. So intermediate macular degeneration, you have numerous medium-sized drusen or one large drusen. And the 5-year risk, remember I told you the 5-year risk of the early macular degeneration was 1.3%. The 5-year risk of advanced macular degeneration within this cohort is 18%. These patients also would be followed. These patients are, it's been shown, would help if they take AREDS vitamins, and I'll go over the formulations with you on what those are, and also be followed by Amsler grid. And the Amsler grid, which I'll show you, it's my last slide, that's a freebie. It's basically a grid which I give to patients to monitor their own vision at home. I tell them to use it every day, and actually if you hold it at actually the right distance, Dr. Amsler was a European ophthalmologist, but it actually simulates the angle between the rods and the cones in the retina. I remember reading that during residency. So it does actually, it can simulate how well rods and cones are aligned within the retina. So if you see straight lines looking wavy, and another thing we can do is that as patients, if you just close your eye and look at a door, you look at you know that a straight line of a door should look straight. You should have straight lines. If you ever see waviness, that's when you want to go to your follow up with your physician for further evaluation. But these sorts of yellowish material, as they break through the retina, can cause this distortion of vision. Advanced or late macular degeneration, you have the non-neovascular type and the neovascular type. In advanced macular degeneration, the vision impairment is more severe, and these patients are followed much more closely. You'll have the presence of drusen and also what's called the degeneration of the retinal pigment epithelium, which means that if you see here, you see this nice bright orange color up here. This is all normal tissue in the retina. This is in the intermediate phase. But if you look here, this retina just doesn't look healthy. It looks mottled. You see these little brownish spots. These are changes in the retinal pigment epithelium. And actually, there's thinning of the retina here. This retina up here looks normal. This retina down here has sort of like this degeneration of the retinal pigment epithelium. And that can, if you look at the central vision where the fovea is, the center of the macula, you'll see that the cells in this area are sick. They have drusen, and they have this deposition of pigment, which can lead to decrease in vision. This is a more advanced case. This retina should look like this nice orange shape here. This is a huge, what's called a disciform scar. If you look here, these are retinal vessels. This is the optic nerve. This entire retina long ago looked like that, or looked like that. A healthy orange retina where vessels are clear, and this center part is what's called the fovea, where you see this depression on what's called an OCT. I'll show you this, an optical coherence tomographer. Advanced macular degeneration. Now, again, what happens in advanced macular degeneration? What's happening is that the retina is not truly, retinas you could think of as being lifted up, but these bad blood vessels, abnormal blood vessels underneath the retina. You have the retina and you have what's called the choroid. Underneath the retina, they are growing, and you can see it here very clearly. This area of hemorrhaging, this is hemorrhaging within the central retina of a patient's right eye. And these little yellow areas are the drusen, but you can see how these vessels have broken through that Brooks membrane, which is underneath the retinal pigment epithelium. And here's another finding from the ARED study, is that 22% risk of if a patient who has advanced macular degeneration has a healthy other eye, they have a 22% risk of having advanced macular degeneration in that other eye within 5 years. So these are patients that you want to get to early, and you want them to monitor themselves. Here's another schematic of what's called choroidal neovascularization, where the choroid, where I told you that great area of blood flow, neovascularization just means new blood vessels have grown from the choroid into the retina. And here's a schematic here again. The retinal pigment epithelium, this little dark line is Brooks membrane. That breaks, blood vessels, here's Brooks membrane. Blood vessels have broken through, and they have they cause swelling of the retina, and they cause decreased vision. I'm not sure how many patients here have had fluorescein angiography done, but if you go to the retina specialist, they will inject a dye in the arm, and they will take photographs of the retina. And this area, this area here is pooling of dye within abnormal blood vessels within the central retina. This retina up here is normal, and it should be the same homogeneous look as this area of pooling of dye. we stratify macular degeneration in what's called classic. We stratify choroidal neovascularization into what's called classic and occult. And the way to think about a classic and occult is, if someone says, oh, they have classic choroidal neovascularization, they're very sharp demarcation lines. You can see exactly where you think the margins of the bad blood vessel growth is in that central retina of this patient. In other patients, it's more indistinct, and there's more seepage, so that if somebody has classic, you have bright fluorescein staining and pooling of dye within these blood vessels. Whereas if you can see over here, this is what's called more occult, where it's less distinct. They're both forms of macular degeneration, and under previous therapies, under older generation therapies than what's done today, they would have implications in terms of how patients, what the therapeutic options were. There's a new management tool called optical coherent tomography, and basically in OCT, it's a real-time view of the layers of the retina without being invasive. And what's nice about OCT is you can actually get a view of the entire retina. Here's a pathology slide going back to our choroid, honoring our Brooks membrane and the retinal pigment epithelial cells. You can actually get a real-time view of the retina through an OCT. Here's a normal retina, and you see the beautiful contour lines. Here's the central fovea, the depression of the central fovea. This area here corresponds with this darker area here in this photograph. But you see the normal, healthy retina. And what I mentioned before, the drusen, if you notice, the OCT here looks, it looks perfect. It looks symmetrical on both sides. You can appreciate layers of the retina. Here, in a patient who has drusen, you see a drusen in the photograph, and you see a breakup of the deeper layers of the retina. Patient who has exudative macular degeneration, advanced macular degeneration, these are bad blood vessels, and here again on OCT, you see swelling or what's called edema of the retina, and you also see a breakup of the nice contour lines of the deeper part of the macula. Here you have some scarring in the central retina, and that also shows thickening. There's thickening of the central retina found on OCT.
Excuse me.
Yes.
What is OCT?
Optical coherence tomographer. It's a diagnostic tool, photographic system that takes. It sends light forms into the eye, and it processes and looks at.
Like a radar sort of?
Yeah, I mean, I don't know. I don't know how to define it any more than that.
Fine.
Yeah. But the nice thing about OCT is that optical coherence tomography is that it's non-invasive. So you're not injecting any dye in a patient's arm. You're taking a picture. There's no harm or there's no downside risk in a patient undergoing that procedure. It's just a photograph. I mean, these are separate photographs, but the beauty of the OCT is that you can actually look at the thickness and of the retina in different areas. So you'll see the thickness here of this patient is 271 microns. And the thickness of the retina, as it changes in patients who are undergoing therapy for macular degeneration, that will affect therapeutic options that patients undergo.
So in other words, that's taking a picture of the whole eye and then giving you depths of view.
Yeah, so actually what it's doing is actually, in OCT, it's actually taking slices. So in this case here, you have a vertical slice. It takes a vertical slice, it takes a horizontal slice. It takes multiple slices, and then you pick the best one. But basically, that's a slice of the central retina. It's not of the whole retina. It's of a vertical line, either horizontal or vertical. What are the risk factors for macular degeneration? As I told you, I speak quickly when I sort of go through it. But other than age, and Tara's going to go over the genetics specifically in your genetics report, but family history, the inheritance estimated has been up to 71%. Macular degeneration occurs more commonly in women. We reviewed the race. It occurs more commonly in Caucasians. A 10-pack year smoking history can double your risk of getting macular degeneration. And there are the genetic factors and complement factors. And if we also, in terms of the, you're going to go over the complement factors? Okay. Oh, so then if you look at various genes have been found to be responsible for different types of macular degeneration down here. Complement factor H, complement factor B, and this gene here, the LOC 387715. And these three together have been shown in a study in 2006 to have almost a 50% risk of macular degeneration if you have each of these three risk factors. Complement factor 3B and H, but complement factor H, I'm actually going to, it's actually a pretty technical definition, so I'm going to, if you'll pardon me, I'm going to actually read it to you. Complement factor H regulates the complement system, and the complement system regulates the immune system's attack on infection and abnormal cells while sparing normal cells. Complement factor H here is an inhibitory gene of the complement system of the innate immunity. And when I was reading it, basically, I think that if you look at this thing called complement factor 3, goes to 3B, complement factor H is inhibiting these areas here. And actually, it's there's a feedback loop complement factor H inhibits complement factor 3B, and it affects the macular complex. And that's if you have these, again going back, if you have these complement factor H, B, and this locus here, you increase your risk of macular degeneration by 50%.
Is that your body not reacting to foreign things, or that it should be reacting?
Part of the immune system response. Do you guys have a better definition than that, Aaron? You guys? How you guys?
No.
Okay. I had to relearn genetics in the last week, so for this time study. But going back to the ARED study, this is how they classified. This is going back to how drusen were classified. Again, early drusen were many small little area of early macular degeneration was many small areas of drusen. This intermediate drusen had this one druse, which is about the thickness of this retinal venule right here. And this is more advanced macular degeneration. So they gave a category 2, 3, and 4. And what they found is that the rate to advanced macular degeneration was decreased in patients who had categories 3 and 4. They looked at patients who were at higher risk of macular degeneration, intermediate and advanced. Their rate of progressing to advanced macular degeneration was decreased by the use of antioxidants and zinc. Patients who took a placebo, their 5-year risk was 28%. And patients who took antioxidants with zinc, their 5-year risk was 20%. Patients, the risk of moderate to severe vision loss was proven by the use of antioxidants and zinc. So the percent with visual acuity loss, the risk of visual acuity loss for each group, and the patients with the patients who took antioxidants and zinc had a lower risk of moderate to severe vision loss over the 5 years. 19% risk reduction. Patients also, risk of developing advanced macular degeneration was 25% risk. Percent with advanced macular degeneration over 5 years in terms of clinical progression. So what we found in the ARED study, or what the ARED's investigators found was the estimate of risk reduction in developing any advanced macular degeneration for intermediate macular degeneration or a patient who had monocular, means one-eyed advanced macular degeneration, by taking antioxidants and zinc was a 25% decrease. Now, antioxidants alone was 17% decrease. Zinc alone was 21%, but them combined, the antioxidants then combined was 25% decrease. These are the final recommendations from the ARED study, which was consider using supplemental antioxidants and zinc for patients with intermediate macular degeneration or monocular one-eye advanced macular degeneration or vision loss due to macular degeneration in one eye. Now, what if you don't meet that? What if you aren't intermediate or advanced, but you're early? They also made a recommendation there. Patients who do not meet these criteria may have a family history or are believed to be at risk should maintain a diet rich in fruits and vegetables, supplement with their diet with a multivitamin, and undergo periodic eye exams. The role of lutein wasn't actually investigated in the ARED study. And now the AREDS is going forward with something called AREDS 2, which is a study that is actually still recruiting patients, I think, in 100 clinical centers, 4,000 patients between the ages of 15 and 85. They're going to evaluate the use of other micronutrients for the prevention of macular degeneration. They're looking at lutein 10 milligrams, zeaxanthine, and omega-3 fatty acids. Right now, there's no evidence for safety or efficacy in 2006, but now that's why they enrolled patients. So often I get questions of, should I start taking lutein? And going back to, I overheard a conversation talking about the smokers. If you have a smoking history, the 10-pack per year smoking history, and really, I treat also, if a patient tells me they were a previous smoker, I say, you're a previous smoker, even if you've been off of smoking for 10, 20 years, I still treat them the same. But some of the new formulations will actually substitute lutein for the beta-carotene. Beta-carotene has been shown to increase the risk of lung cancer in former smokers. And that's why in the AREDS formulations, beta-carotene it's recommended that former smokers or smokers don't take vitamins with beta-carotene. Lutein is a major component of the macular pigment. Here's a monkey pathology of the retina. This yellowish area is lutein deposited in the retina. This is a review of current treatment. Antioxidants reduce the chance of vision loss from macular degeneration. Zinc supplementation also reduces the risk of vision loss, and the combination of the two is even better. Many doctors recommend that their patients take 15 to 20 milligrams per day of the lutein and omega-3 fatty acids, fish oil, or 2 or more servings of fish. Now, again, the AREDS 2 study will help give us better guidance on the benefit of lutein or omega-3 fatty acids going forward. Now I'm going to shift into new therapies for macular degeneration, and going back. If we go back again to see, this is a normal retina where you have integrity of the retinal pigment epithelium and Bruch's membrane and the choroid. That patient can develop drusen, where you have a break in Bruch's membrane and you have this acellular material which grows through Bruch's membrane into underneath the retinal pigment epithelium. Bad blood vessels can form. These new abnormal blood vessels penetrate and proliferate and penetrate Bruch's membrane. And they can leak. And leakage and swelling of the retina is what causes vision to decrease. The current emerging drug therapy for neovascular macular degeneration. When I was a resident, actually, Visudyne had first come into vogue. And what Visudyne was, it's a way to attack what's called VEGF, vascular endothelial growth factor. And patients were injected with Visudyne, and then there was a light source which activated the drug because it deposited preferentially in those bad blood vessels. And using Visudyne therapy, it was shown to have a benefit. I'm going to jump ahead a little bit. Visudyne therapy was shown to have a benefit versus no therapy for patients who had classic choroidal neovascularization. Remember before I told you this patient had classic or occult. These were well-demarcated choroidal neovascularization. By giving a patient Visudyne therapy, they still lost vision over 2 years, but their loss of vision was less if you did nothing. So here, a patient who was on Visudyne therapy would lose 8 letters over 2 years, and a patient who had no therapy would lose 20 letters. Ophthalmologists have standardized what we mean by vision gain or vision loss, and there's a special eye chart. It's called the ETDRS eye chart, where they use a special calibration to sort of to assess gains or loss of vision on a standardized form. So this way, through multiple clinical centers. It's not when you go to the ophthalmologist, they say, oh, your vision's 20/20 or 20/30. That's the Snellen chart. The ETDRS charts are a standardized way to sort of compare them and do statistical analysis on patients who undergo any sort of retina or glaucoma study based on vision. What we found was, so Visudyne was in 2000, when this was approved in 2000, this was a step ahead, because if you did nothing, the old patients before 2000, there was nothing except for laser therapy. You could do laser to the retina to those bad blood vessels to kill the bad blood vessels, and the patients their vision would get worse. But over the long term, it was better to do laser than do nothing. Visudyne therapy found that patients still lost vision over time, but the loss of vision was less than if you did no therapy. Now there are new inhibitors of vascular endothelial growth factor, which are called Lucentis and Avastin. And these studies have found that patients have actually gained vision. And now I'm going to go back, actually, because I jumped ahead. But so what is vascular endothelial growth factor? It's basically a signaling mechanism where vascular endothelial growth factor, the way to think of that is that it is the pathway to which new bad blood vessels are formed. And we've now tried to target the way in which the vascular endothelial growth factor receptor is attacked. So there was something called Macugen, which is you can almost think of it as being a predecessor to Avastin and Lucentis, which is no longer used because Avastin and Lucentis are superior.
Is this when the people talk about wet and dry?
Yeah.
This is the wet?
Wet,
No.
yes.
Okay.
The dry is the drusen.
Right.
The wet is the choroidal neovascularization and the blood vessels flowing through. That is the wet. Okay. So, excuse me, these new drug therapies are targeting the vascular endothelial growth factor receptor. And when we think about, we want to stop what's called angiogenesis. Angiogenesis is the formation of new blood vessels. And that's you want to stop angiogenesis. And here's another schematic showing how vascular endothelial growth factor A, there are many different types, but A is what's used for, is what Lucentis and Avastin target. It's a key mediator of angiogenesis and vascular leakage. So by binding these receptors being activated sends a signal to gene expression, and you get angiogenesis and this vascular leakage and this sort of swelling of the retina. And here's another schematic showing where some of these newer drugs, therapies, will bind on the vascular endothelial growth factor receptors. This is probably beyond the scope. Now, now, how are we treating patients? Basically, patients who have colon cancer, different types of cancers who undergo Avastin therapy, that's intravenous. And now there are formulations of Avastin and Lucentis which are being delivered intravitreally. So that's the medication being injected within the vitreous gel. So again, you have the cornea here, somebody's iris here, somebody's lens where they get a cataract. Here's the retina, and here's what's called the vitreous body or the vitreous gel. The medication is being injected within the vitreous gel, and it's going right towards the leaking blood vessels. I reviewed this. This is the Visudyne therapy, showing that therapy here, the vision still gets worse, but it gets less worse than if you did nothing. But with, these are two big studies called Marina and Anchor, but with the Marina study, it was found that by using, this is ranibizumab, which is the code name for Lucentis, you can actually have, in a third of patients anyway, you have an increase, an improvement of vision over time. And this was another study using Lucentis, showing that patients who underwent Lucentis and Avastin showed an increase, an improvement in their vision for that wet macular degeneration, choroidal neovascularization. Now, the half-life, Lucentis has been shown to be sit in the eye for about 30 days. Avastin for 90 days. Lucentis is actually the drug that was developed specifically for the eye. Avastin was actually developed for colon cancer, etc. But in the time frame before Lucentis was approved, some ophthalmologists off-label started injecting Avastin because there was nothing else. If you did the Visudyne therapy, the vision was getting worse. They wanted to try the Avastin. And so Avastin is actually being used off-label, whereas Lucentis is being used on-label. And there's a cost difference between the two. Lucentis is $2,000 a dose. Avastin, because it was approved for colon cancer, they're aliquoting it down into smaller fragments, and that's about $30 a dose. So the federal government has actually undergone a major study now to do a head-to-head trial to see which is better, Avastin or Lucentis. So that will actually be the future of macular degeneration going forward will be which of these two drugs, Avastin or Lucentis, will be superior in treating macular degeneration, number one. Can you use these two drugs or other drugs that are formed, can you use them in combination where they attack these, the vascular endothelial growth factor receptors differently? And we also look at what can help to prevent macular degeneration. These are, the American Academy of Ophthalmology has what's called preferred practice pattern. I've actually reviewed everything that we've said in these next couple of slides, but I brought them up just to review them again. In terms of if a patient has early macular degeneration, that category 2 that I mentioned, they should return every 6 to 24 months if they're asymptomatic. They can take photographs, but they don't need fluorescein angiogram where they inject the dye in your arm and take the pictures. If they have very advanced macular degeneration with geographic atrophy, that modeling of the retina which I showed, they also can be observed. But patients who have intermediate or advanced in one eye would benefit from the vitamins by the ARED study. Okay, actually, and there's the image grid. But this was in the New England Journal of Medicine last year, a review article, which showed, again, going through the early, intermediate, advanced non-neovascular and neovascular. This is that large drusen I showed you, which is more than 125 microns. These are those very small drusen, and this is the breakup of the retina with drusen coming through this barrier between the retina and the deeper and the choroid. Amsler grid testing. If you use an Amsler grid, you generally have it between 12 and 14 inches from your eye. You cover each eye with your reading glasses, and you're asked to look at the center dot. When I ask patients to look at the center dot, I ask them to describe what they see. Do the lines look straight? Can they see the borders of the Amsler grid? And do they look wavy? And in Amsler grid testing, this type of change actually would cause you to go in. This doesn't just happen in macular degeneration. Other types of retinal entities will cause changes to an Amsler grid. My first year of practice, I had a young patient who was in her 30s. This was published in the paper. It was in the Philadelphia Inquirer, and she came in. She said, I was reading the paper, and I saw that I had some changes to this grid in the paper. And she had a different form of, she had something called central serous retinopathy, but she had swelling of her retina, thickening of her retina, which caused a breakup between the rods and cones and cause her to see waviness of lines. I know I went through it fast, but questions?
Yeah.